Hello viewers, welcome to Dr. PK Medical Lectures. This video is intended solely for educational purposes and it is meant for medical students. Hi, I am Dr. PK. In this video, we will discuss tuberculous pleural effusion. Our discussion will be on these following topics. Number 1, pathogenesis. Number 2, clinical features. Number 3, pleural fluid analysis. And number 4, management. Tuberculous pleural effusion is the second most common extrapulmonary manifestation of tuberculosis next to TB lymphadenitis. It is seen both in primary tuberculosis and in reactivation of tuberculosis, that is adult type disease. First we see the mechanism of tuberculous pleural effusion. The main mechanism is a delayed hypersensitivity reaction. Let me explain in detail. It begins with the subpleural pulmonary focus due to overgrowth of tubercle bacilli. In cases of primary tuberculosis, this pulmonary focus is seen either in the middle lobe or upper part of the lower lobe. In cases of reactivation of tuberculosis, this pulmonary focus is seen in the upper lobe. From this pulmonary focus, the tuberculous proteins are released into the pleural cavity. These proteins act as antigens and activate cell-mediated immune response by type 4 hypersensitivity reaction that leads to infiltration of CD4 T lymphocytes and macrophages and causes inflammation. It is because of this inflammation there is increased permeability of the capillaries and also there is obstruction of the lymphatic flow by the organizing granuloma. All these factors lead to accumulation of fluid in the pleural cavity, which is always an exudative pleural effusion. So the main mechanism is a delayed hypersensitivity reaction to tuberculous proteins which are released from the pulmonary focus. At this junction, I would like to emphasize two important points. Number one, the pleural fluid is paucibacillary, which means it is very difficult to isolate the organism either by culture or even by nucleic acid amplification technique because this pleural effusion is not due to direct invasion of bacilli. Then regarding this parenchymal lesion, this lesion is in its initial stage, which means there is no consolidation or cavitation. So if you take a chest X-ray, what you can see only the features of pleural effusion. It is very difficult to identify the pulmonary focus. Even if you take CT thorax, you can see only minimal pulmonary infiltrate along with the features of pleural effusion. This is regarding the mechanism of tuberculous pleural effusion. Now we move on to clinical features of tuberculous pleural effusion. Fever, cough, pleuritic type of chest pain and dyspnea are the most common symptoms of tuberculous pleural effusion. Regarding the fever is subacute in onset. It is low grade intermittent fever with evening rise of temperature and or night sweats. Then cough in this type of tuberculous pleural effusion is dry cough and it is mainly due to pleurisy. Then pleuritic chest pain is one of the most common symptoms of tuberculous pleural effusion. It is sharp and stabbing felt in the infraaxillary and infrascapular region, and it is aggravated by deep inspiration and cough, and it is relieved by shallow breathing and lying on the side of lesion, that is splinting of the chest wall. So description of pleuritic type of chest pain is very important. It is stabbing in nature. It is always felt in the infraaxillary and infrascapular regions, and it is aggravated by deep inspiration and cough, and it is relieved by shallow breathing and splinting of the chest wall. Then dyspnea. The most common mechanism of dyspnea is pleurisy. Other mechanisms are because of rapid accumulation of fluid or because of massive collection of fluid which can compress the lung. So these are the mechanisms of dyspnea in tuberculous pleural effusion. Then hemoptysis is not a feature of tuberculous pleural effusion. Loss of weight and loss of appetite are associated features for tuberculosis. Now we move on to signs of not only tuberculous pleural effusion but any pleural effusion. Mediastinal shift is an important feature of pleural effusion. In pleural effusion, the mediastinum is shifted away from the side of lesion. So in cases of right side pleural effusion, the trachea is shifted to left side and also the apical limbals. Then regarding the endocostal space, there is widening of the endocostal space, and in cases of massive pleural effusion, you can see fullness of endocostal space. And always there is a restriction of movement on the side of lesion. Stony dullness is another important feature of pleural effusion. While describing or while doing percussion, in cases of right-sided pleural effusion, one has to mention about tidal percussion. In cases of left-sided pleural effusion, one has to mention about obliteration of trough space. Then regarding the auscultative features of pleural effusion, the breath sound is diminished, vocal resonance and vocal fermenters are reduced, and there is no added sound. So the features of pleural effusion are: number 1, mediastinal shift; number 2, widening of intercostal space; number 3, restriction of movement on the side of lesion; number 4, stony dullness; number 5, reduced breath sound; number 6, reduced VF and VR; number 7, no added sound. Then regarding the radiological features of pleural effusion, which is the most striking is homogeneous opacity. That is, the opacity will look like a cardiac shadow. Then obliteration of the costophrenic angle. Then mediastinal shift away from the side of lesion. Number 4, regarding this opacity, it is more radiodense in the lower part of the lung. Once you go upwards, it becomes a radiolution. Then meniscus sign is an important sign seen in chest X-ray. That is, the upper level of pleural fluid is higher in the axilla and it is concave in shape. So the radiological features of pleural effusion are: number 1, homogeneous opacity; number 2, obliteration of costophrenic angle; number 3, mediastinal shift; number 4, the opacity is more radiodense in the lower part of the lesion; and number 5, meniscus sign. Now we move on to pleural fluid analysis in tuberculous pleural effusion. The appearance is clear and straw colored. Being an exudative pleural effusion, it fulfills the Light's criteria. The cell count is high. It ranges from 1000 to 6000 cells per cubic millimeter. Then regarding the differential count, lymphocyte predominance is the characteristic feature of this tuberculous pleural effusion. So they are lymphocyte predominant. In fact, the lymphocyte to neutrophil ratio, if it is more than 0.75, it favors a diagnosis of tuberculous pleural effusion. Then regarding the other cell count, that is, if the mesothelial cells are more than 5%, or if the eosinophils are more than 10% of the cell count, it almost rules out tuberculosis. So more than 5% of mesothelial cells or more than 10% of eosinophils in the pleural fluid rules out tuberculous pleural effusion. Then the protein content is high. It is 3 gram per deciliter. Even it can reach 5 gram per deciliter. LDH is also high, it is more than 500 international unit per liter, and glucose is low, it is less than 60 milligram per deciliter. Then the pH is 7.3, whereas the pH of normal pleural fluid is 7.4, that is slightly alkaline. Adenosine deaminase and interferon gamma are two important investigations that are highly specific and sensitive for the diagnosis of tuberculous pleural effusion. If the ADA value, if it is less than 30, it has got a negative predictive value. If the value is 30 to 70 units per liter, then there is a possibility of tuberculous pleural effusion. But if it is more than 70 units per liter, it is specific for the diagnosis of tuberculous pleural effusion. Then interferon gamma, it is not done routinely because it is expensive. But if the value is more than 140 picogram per ml, it is highly specific for tuberculous pleural effusion. So remember these two values, 40 and 140. 40 for adenosine deaminase and 140 for interferon gamma. And isolation of organism from the pleural fluid by AFP smear, culture or CB naught, all are negative. All are usually negative. As I already told, the pleural fluid is paucibacillary. Next, the most important investigation for diagnosing tuberculous pleural effusion is pleural biopsy. Pleural biopsy is highly valuable for diagnosing tuberculosis. In pleural biopsy, the bacilli can be detected by nucleic acid amplification test, which also identifies drug resistance. The organism can also be isolated by culture. It usually takes 6 to 8 weeks. Then presence of caseating granuloma confirms the diagnosis of tuberculous pleural effusion. This is regarding the pleural biopsy. Chest X-ray shows only the features of pleural effusion. It is very difficult to identify the pulmonary focus. CT thorax may show some minimal pulmonary infiltrate along with the features of pleural effusion. Then tuberculin skin test, interferon gamma release assay are supportive tests for tuberculosis. Sputum AFP and culture are always negative. So this is regarding the investigations for tuberculous pleural effusion. Coming to the diagnosis of tuberculous pleural effusion, definite diagnosis. Isolation of Mycobacterium tuberculosis in pleural biopsy specimen by culture or by CB naught confirms the diagnosis of tuberculous pleural effusion. Then presence of caseating granuloma also confirms the diagnosis of tuberculous pleural effusion. So the definite diagnosis of tuberculous pleural effusion is made either by isolation of the organism or by the presence of caseating granuloma in the pleural biopsy specimen. But if the patient is already a proven case of pulmonary tuberculosis, it is not necessary to go for a pleural fluid analysis. And coming to the after ruling out other causes of pleural effusion, we can have a presumptive diagnosis of tuberculous pleural effusion by the following criteria. Number 1, lymphocyte predominance with lymphocyte to neutrophil ratio is more than 0.75 with the value of adenosine deaminase more than 40 units per liter, along with the supportive tests that are positive tuberculin skin test and high interferon gamma. This is how a presumptive diagnosis of tuberculous pleural effusion is made. Next, we move on to management of tuberculous pleural effusion. Tuberculous pleural effusion is treated with anti-tuberculous therapy similar to pulmonary tuberculosis. 2 months of intensive phase with isoniazid, rifampicin, pyrazinamide and ethambutol, and 4 months of continuation phase with isoniazid and rifampicin. Then regarding the need for intercostal tube drainage, that is therapeutic thoracentesis, normally it is not done because it is self-limited. It resolves on its own within a few months without going for any complications like calcification or organization. Still, we have indications for therapeutic thoracentesis. Number 1, in cases of massive pleural effusion. Number 2, if the patient is more symptomatic. Number 3, for the rapid relief of the symptoms. Then the role of steroid, it is controversial. Steroids are not usually given, but we have indications for steroid in treating the tuberculous pleural effusion. Number 1, in cases of massive pleural effusion, or if there is a severe pleuritic type of chest pain, or if the patient is has more systemic symptoms. So these are indications for steroids. Other less common cause of tuberculous pleural effusion is TB empyema. So far we have discussed tuberculous pleural effusion which is the delayed hypersensitivity reaction to the tuberculous protein. But in TB empyema there is a direct invasion of the bacilli and there is a multiplication of the bacilli. There are a few conditions which can introduce this tubercle bacilli into the pleural cavity. In cases of primary progressive pulmonary tuberculosis, rupture of either this lymph node or rupture of this gone focus release bacilli into the pleural cavity. So there is a direct invasion of the bacilli. In cases of adult type disease, the generation of bronchopleural fistula paves the way for the entry of bacilli into the pleural cavity. And if there is a rupture of cavity filled with secretions, it causes spillage of fluid and a massive infiltration of bacilli into the pleural cavity. So in all these conditions, there is a direct invasion of bacilli with multiplication. So the features of TB empyema are: number 1, chronic. Number 2, they are recurrent. Number 3, they are always neutrophil predominant. Culture nucleic acid amplification technique are always positive because of the multiplication of the bacilli. It always needs intercostal tube drainage. More patients need surgery because of the complications. Thank you for watching my video. Please like, share and subscribe Dr. PK Medical Lectures for more clinical related topics and discussion on medical exam cases. Thank you once again.